Welcome. Really great to see all you on screen. And this is actually going to be two sessions. One today, which is a sort of introduction to the Optimal Health Program, and then there'll be one on the 12th of April at the same time, which will be the follow-up. And what we'll do is to step through a number of slides. You can have the slide sets as well, and as Davis has said, we already have distributed the workbooks, and the idea is to familiarize yourselves with a sort of helicopter overview of what the Optimal Health Program is. In the future going forward, for those who wish to adopt and use the OHP, you should know that it's an advanced stage of being a digital offering, and we're also working on a sort of community of practice model across Clarity and our other brother and sister organizations for supporting OHP practitioners, and we'll have a monthly forum for that and for problem solving and case presentations and so forth. But we'll let you know a bit more about that in due course. So the Optimal Health Program is a program which had its genesis about 30 years ago. And the genesis was that me and a group of practitioners decided that we would look at models of care for people with mental health problems. And we, in the process of that, spoke to a lot of practitioners and clinicians, and also to a lot of patients and carers. And a lot of people said that having a mental illness was tough yakka, which it is, or it can be. But also having physical and mental health was double difficulty. And then if you had substance use thrown into on the top, that was even more difficult. And that the system is very complicated and difficult to negotiate. That is the healthcare system. And then, of course, all the other systems like Centrelink and goodness knows what. So we spent some time, as one does, bemoaning the failings of the system. And then getting back to reality of what we could actually do, we acknowledged we couldn't rebuild the whole system. And we needed to acknowledge that the still point in people's turning world is themselves. And a lot of patients in particular and families felt very disempowered by the system, and they felt sort of at the mercy of both their mental health problems on one side, physical health problems on the other side, and then by the system itself. So this was a sort of wake-up call to us. And instead of sitting around and moaning more about the system and the failings of the system, we thought we'd just try and turn everything on its head and work specifically with the individual to empower them and build what we would refer to as self-efficacy, which of course is a Bandura's term. And it really puts the emphasis on the individual learning skills to manage stuff themselves. And it also shifts the focus from a crisis-driven clinical response system, which is very common, by the way, and not very adequate for obvious reasons. And the other thing, that it tended to focus on illness rather than wellness. So it puts a whole lot of things on their head and says we should empower individuals as our primary objective, build around them a structure to support them, give them tools to support them in their life journey and their journey with mental health problems and physical health problems and so forth, and also make sure that we were doing that in a comprehensive manner and in a manner which we could actually assess in an ongoing way. And I'll just give you the heads up that this has grown over 30 years into a program which has trained up and skilled up numerous practitioners around the world. We do have some lovely cultural adaptations, and I'll talk a little bit about those. For example, we have a Malaysian and Indonesian version, and we have done some work with Aboriginal groups as well. So the idea for today is to give a whole very big team who've worked over many years to develop occupational health program, and there's acknowledgements to all of them at the end. So I'm going to give you an overview of the program itself. As I said, its genesis was in this idea about building self-efficacy, and it adopts what is called a salutogenic approach. Now, salutogenic means really putting the focus on wellness rather than illness. And the idea of it was to help people managing their symptoms, their behaviors, and develop a set of plans for well-being. And this is very much driven by the individual. I mean, it is a manualized program. It delivered in a set of modules with a set of tools which are taught and practiced. But at the end of the day, there's a lot of personalization which can be done. And that's an ongoing iterative process. So as an OHP practitioner, you would adopt the approach of not you standing here teaching this program. It's you and the participant working together with the program. And interesting sort of side of that was that we had initially a therapist workbook and a patient or participant workbook. And eventually through all of it, we decided we'll just make one workbook because everybody should be on the same page and working to the same and dancing to the same song. And that's been the spirit in which we've taken it. We also realized that we were not in a position where we should or should strive to abandon everything which had gone before, but indeed build on and bring in elements of practice which are well established and which we know work. And all of you practitioners would recognize as we step through this various elements of behavioral therapy, cognitive therapy, and motivational interviewing therapy, approaches. All of these things are in here, but it's delivered in a certain way which hopefully is more acceptable and able to be embraced by the individual and customized to the individual, and eventually becomes driven by the individual. It is evidence-based. As I said, we've had masses of trials of this. We've had large-scale randomized control trials. We've had hundreds of scientific publications. So it is validated as well, and the outcomes are generally very positive, both in terms of quantitative and qualitative outcomes, and seem to be driven by the enhancement of self-efficacy. The other part is it's not something you do alone. Yes, you have your practitioner to help you to develop the skills, but also as part of the whole process, you can build your team around you, and that can include anyone you really want to. And I'll talk about how that's done later. So it does require the practitioner to create a learning environment. And this is a lot of fun, actually. When I looked at this initially and started to develop OHP, somebody said, well, I hope you're doing it with all your patients. And I said rather embarrassedly, well, no, I just incorporate all the elements anyway into my general practice. And, I've had this many years experience. And then I thought, actually, that's wrong. What I need to do is to actually get behind it and walk the talk. So I sat down with a patient and was working through the workbook with them. And I thought, oh, that section you're not going to really relate to and won't find very helpful. So I was about to, turn over and carry on. And the patient said, oh, if you don't mind, that looked quite rather interesting. I might ask whether we can talk about that. And he found that element of it very, very helpful. So it show all of it to people, make them help them to make the decisions about what is going to be helpful for them. Don't prejudge it. We're not very, good at reading minds, right? And it is meant to be an iterative process, and it's not meant to be anything static, by the way. You develop at the end of it these 3 health plans, which I will talk about, but they, again, are not meant to be static. Nothing in the world of health is static because, diseases change, we change. So, for example, with somebody with diabetes, you wouldn't say, well, this is your average blood sugar and this is your dose of insulin, and see you at the end of your life. You're going to review them regularly, and they're going to be reviewing their blood sugars regularly, and they're going to be trying different ways of manipulating their diet and their insulin dose. And if a new delivery mechanism like an insulin pump comes out, you might consider that. So, the idea is to have this active engagement with both you, the rest of the team, and the individual around what is best for them, and continue to ask the questions about how it could be tailored to them. It's very much consumer driven, and it's very hard, as you will see, and I've already said, building self-determination. And there are tools which we teach, and I will share those with you as we go. The 2, just to give you the heads up, one is the I Can Do model, which is essentially a strengths vulnerability model, and then the health plans, which really cement all the learnings and build processes to keep yourself well in the longer run. The notion of health literacy is something which worldwide is problematic. We have done probably not a terribly bad job in Australia at building health literacy amongst some individuals in the population. So people are more au fait with health literacy as well as mental health literacy, but there's still a lot of aspects of health and the attainment of health and the ongoing benefits of healthy living, which are lost on a lot of people. So we need to build on the skills and knowledge which people have, and through this process, further develop health literacy. And that it defines itself in terms of being, to some degree, self-determined and self-defined, and being a self-advocate. But as I said, many people with mental health problems in particular feel very disempowered, and that nobody really listens to them. People only respond to them when they're ill rather than when they're well, and that they don't have self-agency. And self-agency, that's the ability to make decisions and choices for yourself, arguably is one of the few things humans have as different from the rest of humanity, or the rest of the other animals. So OHP is consistent with national frameworks and very much recovery orientated, and is holistic, personalized, and allows organizational commitment and workforce development as well. So part of this process is to offer you both clarity, but also our partner organizations, the ability to pick up OHP and work with it, and to offer it to your patients. I'm going to keep talking through and not stop because of the format we have today, and apologies for that. We will, at the end of the whole 2 sessions, to have some time for discussion, and even for today I will stop for discussion 10 minutes from the end, but in the meantime I'll just keep going because you'll get an oversight of it better if I do that. So here's the Optimal Health Program architecture. It has originally in its original iteration 8 discrete sessions, which are meant to be done sequentially. Once you become very au fait with OHP, you can depart from this architecture to some degree, and you can bring certain things in at certain times. But I would suggest for the first at least 5 or so patients, you take through it, just stick to this architecture and this sequence, because it's put together in a way which makes sense. By the way, we had a lot of input in original design from a group called the De Bono Institute, who are, the genesis of that was with a cardiologist from Malta called De Bono, Edward De Bono, who you might know is an educationist. So this very much brings a pedagogical approach to it, and we adapted the original very text word heavy offering to a much more visual offering, which is what you see today, and we're going to develop that further. We build over these 8 sessions the first beginning, which is about what is optimal health. And people often haven't really thought about that. Of course, there's the WHO definition, which is a little probably unrealistic and aspirational, but not bad in itself. But what's more important is what it is and what it means to the individual. And then we can bring in things about change. So you can say, where are we? Where are you? What are the things you might like to work with and work on? And what are some of the tools which you've already tried? What's working for you? What's not working for you? And so forth. We then work on starting to try to enhance self-efficacy, which is strengths and vulnerabilities. And that's linked to Health Plan 1, stressors and strategies, and that's linked to Health Plan 2. We do build in a discussion about medication, but you can see how medication is the 4th thing that we get to, the 4th session. And this surprises a lot of people because they're used to, doctors in particular, falling into the trap of making a decision about focus on the person's symptoms. So we'd ask about psychotic symptoms, for example, and then we would talk immediately about medication, and that would be about as far as it goes. This program offers a very different longitudinal strategy where it's much more about listening to what the individual wants to get from this, and then saying, well, we've talked about strengths and vulnerabilities, we've sort of about management of those stresses in your life. Medication might be part of the answer for all of this. So it's bringing it in a way which is softer. It's also stressing to the person we're most interested in them, rather than in our medications and getting the medications into their mouth. And for non-clinicians or for people who are not au fait with all the medications, we've actually brought in a very, very comprehensive booklet to support the discussion about medication. It has all of the details about pretty much all the medications we use in psychiatry, the pros and the cons, and the likely side effects, and so forth. So that's available as part of this whole package, and we're busy refining that a little bit as well to make it more easy to use. Also, we have the capacity to bring the doctors in on this if people want that. You can bring one of the doctors in as a for just one session if you want. The next step is building your collaborative partnership. I refer to people as collaborative partners in this because that's what they are. They shouldn't be. There's nobody telling other people what to do. It's all working together, and that includes a strategy called eco-mapping, which is where we put the individual at the middle of the sort of dartboard diagram and plot the people around them. And that speaks to Health Plan 3, which is the health plan which you need when things go wrong or don't go as right as you might like. So I'm going to just loop back to the health plans because I've already alluded to Health Plan 1, 2, and 3, and they are sort of products of OHP, which keeps you going in the longer run. I'll just explain what I mean by these. Health Plan 1 is about the things you do and the things you should continue to do to keep yourself well. equivalent of driving on a nice sunny day on a nice road with no potholes and everything's just going nicely. You still need to be paying attention to what you're doing. You need to, check your rearview mirror and make sure your tires are pumped up, and you need to keep the engine running well. So you're putting in oil and you're putting in the right octane fuel. That might be, seen as an analogy for medications. And good diet to keep the engine running well. But remember, you have to drive the car. So health plan 1 is around that every day. Hopefully you will spend most of your time under those driving conditions. However, stresses happen, and stresses in this road driving analogy would be, for example, if it's a stormy weather, that there's flooding on the road, or there's potholes, or it's a gravel road, or there's twists and turns through a forest or something, then you would need to employ certain strategies. The strategy shouldn't be to slam on the brakes and slide off the edge of the road, and it isn't panicking. It is about maybe slowing down, maybe looking at what other people could come in and help you if necessary. It could be using, your braking system, so all-wheel drive and your automatic braking. All of these sorts of things are strategies which you would deal with those particular stressors. So that's health plan 2. And health plan 3 is, as I said, when things don't go quite as well as we might like, and that happens. And people might land up in hospital. That's the equivalent of breaking down in your car and being towed in for repairs. It's not a disaster, and we can in fact use it as a learning opportunity. So this is another one of the tools which we'll teach, and I'll show you this later, is to actually go back and say, well, you had an accident or the car broke down. What was the stuff which happened to you leading up to that? And what could we have done differently? And I say we, that means not just the individual and putting the blame on them. What could the whole system around you have done differently? Who could you have called on? Could you have, been more driving slower on the road? Could you have made sure you took yourself in for your car in for a service, which might be, a planned admission to hospital or day program or something? So you can get the idea. I don't want to stretch this analogy too far. I do like the car analogy. I'll just let you know some of the cultural adaptations. In Indonesia, as you can probably imagine, they went immediately for the little buzz bikes because they're ubiquitous. But in Malaysia, it was so lovely, they morphed it into a plant, and the idea of planting a plant and watering the plant and watching the plant grow. So whatever analogies I use, you don't have to use, you can develop your own. And then we move on to change and enhancing change through visioning and goal setting. And here we bring in things like SMART goals and so forth, and also celebration. It sounds a bit naff maybe, but I think this idea about celebrating success is really important, and not beating yourself up for lack of success, but asking why you're not achieving that success and what can be done. And then there's a condensation of all of this knowledge into the health plans, which the person actually holds themselves. As I said, they can use in true life. They can also use opportunities going forward to see what works and doesn't work and adapt things to some degree. And you can also offer boosters. Very common that people need things to be revisited. We all find that. So I'm going to talk for about another 20 minutes, and then I'll open it up for discussion. The OHP delivery, as I said, and I've shown you, is an 8 weekly sessions. It doesn't have to be done weekly, and it can actually be broken up into as many sessions as you like. So we had some patients who were just so unwell or disorganized or anxious that they couldn't sit through a whole hour, which is roughly what it takes. So we would say, well, that's fine. We'll do 15 minutes now, and then we can pick up and do 15 minutes later at a later time. What is really important, though, is the work that they do between sessions. So you would give them something to do, as in pretty much every psychological model, between sessions, and to report back. It is possible to do it in groups or individually. Groups are really a lot of mutual learning within the groups, and it's unfortunately something which we probably don't do enough of. Hopefully, through the partnership we have with so many of your great organizations, we'll be able to do more group work. And it's very, very, very adaptable. So it's very much about the person. But, be aware of the imperatives around not exhausting people. And the other thing is, just to make absolutely clear, this is not saying that OHP is the thing which you do. OHP is a vehicle for delivery of good, hopefully good healthcare and wellness care. And the idea is that it doesn't cut across any of the other skill sets which you have, which we acknowledge and appreciate very much. And in fact, that we got all different disciplines involved in this endeavor is a strength, and we should continue to embrace that as a strength. So it doesn't mean that you can't go off and ask, if your patient, for example, it lands up that they finding great difficulty with drugs and alcohol as a problem, then you could bring in somebody who could help specifically with drugs and alcohol. Or, if they're having problems with housing, you can negotiate with the housing system or whatever. You get what I'm getting at, I hope. These are the resources we have, to add to this this booklet, which you already have, but to add also that we, as I said, very far advanced with a digital offering, which will make a whole lot of this stuff a whole lot more accessible and easier. I'd like to talk a little bit about the practitioner and the practitioner stance, and this is from Harley Anderson. And it encapsulates nicely the ethos here. So the therapist is not an expert agent of change. That is, a therapist does not change another person. I was interested in this just last night. I went to the symphony and I was sitting next to somebody who immediately told me, by the way, she had ADHD and was on the spectrum, which I thought was rather interesting. And then she realized I was a psychiatrist, and that took this discussion in a rather different way. But we talked also about change and whether you can change people. And we agreed that you don't change people, but you can help people to learn stuff about themselves and their interaction with the world, which can be hopefully enhancing of the appreciation of the individual and the appreciation of the world. But the therapist does have expertise. And, we talk about shared decision-making. I'm very supportive of shared decision-making. But it has to be both ways, that, we have, as therapists, a lot of expertise to bring to individuals, but they know about their own self and must bring that to the discussion. And again, with the car analogy, it's a bit like if your car breaks down and you take it into the service station. I know very little about cars, so I'm going to say, well, this car isn't running properly, and I can hear the engine doing this, and it's not pulling properly. But you need to have a look at it and tell me what's going on, and then give me the options. You don't just jump in and put in a new engine and charge me $20,000. You're going to give me your expert opinion about what's wrong, what you think might be wrong, and what tests need to be done, and then what the solutions might be, and the pros and cons. This is how we should practice shared decision making, in my view. And here Charlene Anderson says, when involved in this kind of process, both client and therapist are shaped and reshaped, transformed as they work together. And that's so lovely. And it's one of the great joys of psychiatry and mental health work, that we almost have to be involved on a level where we are enriched by our clinical work, and it's a great privilege for us. And this is very much embraced by OHP. Talks about engagement and collaboration, mutuality, respect, hope. Hope is a very important driver, but it needs to be realistic. I think that it's unfortunate that some people, some organizations tend to give a message of hope, which is just simply unrealistic for some people. And that, I think, is detrimental, because if you can never achieve it, then there's no point in fooling people to think that they can, because if they fail, they'll take it as a failure of themselves. This notion of mutual inquiry, and as I said, this is so much about not you telling the person, it's you and the person working together with this tool set, which is the OHP tool set. And, sometimes you're going to run up against not knowing. Well, that's okay. Obviously, you can try and puzzle it through together, rather than saying, well, I can't possibly let the patient know that I don't know something. Uncertainty, I always say, if you are unable to live with uncertainty, psychiatry is not going to be the thing for you, because you have to, because it is uncertain. Life is uncertain. People are uncertain, and the universe is uncertain. Accepting of it, and accepting with uncertainty and living with it, is one of the things we have to do as practitioners. So the steps include engagement, focus, evoking, and then planning. And this is part of the engagement cycle, and this is obviously a very important set of principles. I won't dwell on them, because you are a highly trained group and would know about a lot of these issues, about how you engage people in an empathic way, and so forth. And Marco D'Asio, who did a lot of work with us on OHP, put it together in this way, to put well-being at the middle, and looked at how your personal recovery, which is self-defined, self-determined, and entails self-advocacy, feeds out to collaborative processes, engaging, planning with others, and then this notion of the cycle of engagement with a reframing, detach, undetach, and you can start to hear the sort of phraseology associated with certain psychological models, for example, with ACT, detaching. I know there's different terminology used, but it's you get the idea of not hooking yourself on and being hooked on to negative ways of thinking. So if we were running this as a workshop, which we're not, but we can if people wish to, we would take a break and ask people to consider the principles of OHP and how you would engage somebody in OHP, and then it gives the coaching skill set. But I'm going to carry on for another 10 minutes with your forbearance, and dive into the beginning of the actual program, and then we'll take a break, and then in a month we'll come back. So this is the overview of what is in the program, and you can see how many of these things you would know about. So collaborative therapy, hope, self-determination, growth mindset. That comes from Carol Dweck, who worked a lot with the idea that young kids, if you help them to see their brain as a sort of muscle which can be developed, then that you get away from them feeling negative about themselves if they're not brilliant in terms of the ability to change. And they did this fascinating experiment where they showed they took a group of kids and they gave them a maths problem, and half the kids were battling with the maths problem, but they said to them, you're trying really hard. Sorry, they gave them an easy maths problem, and the kids did it pretty uniformly well. And they said to half the kids, you're trying really hard and putting a lot of effort into that's great. And to the other half of the kids, they said, oh gosh, you're smart, you just get this with no problem. And then they increased the difficulty of the maths task. And the kids they had messaged with you trying hard, that's great, that's valued way of going about solving these problems. They continued to battle through and managed more and more difficult maths problems. The kids they had said, oh, you're smart, you just do that with ease, no problem. They just started giving up. So it was fascinating about human psychology and how the brain works. So this shows just one of the underpinnings which the de Bono people introduced to us is growth mindset, and then self-efficacy, strengths-based, you will know, recovery orientated, and so forth. An idea is to get this balance of health, mental health, maximum, minimum in a balance, and not to strive towards perfection, because no such thing as perfection, and if it was achieved, the world would be excruciatingly boring. We acknowledge, of course, individuals and environment and social and other factors in people's lives. So we don't just talk about them, we talk about this environmental stuff. And then we dive into the actual program. And I'm going to stop very shortly, but just to tell you also, we are very keen on assessment. So we build in some assessment tools. And some of those assessment tools are, well, in fact, all of the assessment tools are clinically relevant and can be shared with the patient as well, because they can then get a sense about how they're going, what they're benefiting from, what they're not benefiting from, and then we can aggregate those to get pooled outcomes for people. So just measuring things for their own sake is not of interest. This is beginning session 1. So I'm going to stop, having spoken for about 45 minutes on the background and the genesis, with a view to having a little discussion now, and then to introduce to you the session-by-session approach which OHP adopts. So thanks for your attention thus far, and I'm sorry if there's frustration at not